El Colegio Mexicano de Ortopedia, en su 75 aniversario, presenta su segundo Congreso Virtual 2021. El doctor Christopher O'Grady es egresado en Medicina por la Universidad de Medicina de Georgetown y se ha certificado en Medicina Deportiva. Realizó su residencia en Ortopedia en la Facultad de Medicina Albert Einstein y en el Departamento de Cirugía Ortopédica del Centro Médico Judío de Long Island en New Hyde Park, Nueva York. Actualmente es especialista en medicina deportiva en Gulf Breeze, Florida, y ejerce en Baptist Physician Group. Está afiliado a Ascension Sacred Heart Pensacola. El doctor O'Grady hablará sobre técnica equivalente transósea de doble hilera.
Thank you very much. Thank you for the invitation to speak today. I was invited to speak about double row techniques in the fixation of rotator cuff surgery. And I'm going to just show you very quickly a technique that I've been using for about 14 years or so. We all know that there is controversy about the use of single versus double row. And in smaller tears, clinical evidence would suggest that single row repairs would be acceptable in some situations. But certainly with larger tears now, there's evidence that double row repairs are important. Even early on, we knew that the highest ultimate load to failure and resistance to shear and other biomechanical tests showed that double row repair was significantly improved. And so I think it's fairly common now in large chronic tears, especially, we're all moving to double row repair techniques. Is more better. There are certainly other things to take into account. We know single row is successful. If you put too many anchors and do too many sutures, there are questions of blood supply. There are cost considerations. Anchors are not free, and so the more that we use, the more expensive the surgery is, and so we need to justify it. There are certainly time considerations because each anchor does take more time to put in, especially for someone who might be just starting out and their comfort and skill level may not be where it is where they enjoy putting in that many anchors. And as I tell the fellows, it can be a little scary. So this is a good day in the OR. We've all had these days where you've got a tear, everything looks pretty good, you're flying high, everything is aligned, sutures are beautiful. And then you have the not so good day where for some reason you turn over and you look back and there are sutures all over the place, tangled. It might have just been one little mistake and all of a sudden you don't know which way is up, which way is down. You start to get nauseous and angry, and we want to avoid those types of days. So in order to avoid those types of days, I came up with this technique, which was to basically just to minimize the headaches, also to minimize the steps and maximize the efficiency of your procedure. You want to get the maximum out of your implants with the maximum points of fixation, and also to maximize the surface area contact of the rotator cuff to the footprint. So the technique I'll show here is great for crescent tears. It can be modified for larger crescent tears. It can be used for U-shaped tears once the U-shaped tear is converted to a crescent tear just by a few margin convergent sutures. So as in most techniques, we establish first with the medial row. What you'll see here really is certainly, it's no different, I'm sure, than many techniques that have been used now. This is really just simply my technique that I've been doing a long time, and I try to do it efficiently the same time every time. But as you'll see at the end, it's going to look very similar to most double row techniques that you've got. So for me, it's important to really try to get these medial row anchors right there at the articular margin after clearing the footprint. And we're going to start with medial row mattress sutures. And so we want to establish the medial row by passing in these double loaded anchors. We're going to just pass the darker blue suture on the first pass. The second pass includes actually shuttling the other 3 sutures from that same anchor. So we're going to create a passing suture. You can use one from some companies that are pre-made and very expensive. You can make your own by tying this double looped square knot with a much less expensive technique. And so that second pass involves creating this loop and then passing the 3 sutures through it to pull through. So you pass the free end, you retrieve it out the other cannula, you grab the remaining 3 sutures from that same anchor, you bring them through, pass them through the loop as you see on the left here, and then you shuttle all 3 sutures through. One thing I do differently, this is about a 12-year-old video, one thing I do differently now is I will start sewing from the front anchor and then progress back so I can skip the step you see now, which is once I've passed all those sutures, they're kind of in the way and in my face. So that is one modification that I do now. And so after you get the second pass, you get this situation here where you've got some tissue between your throws. The blue sutures will create your mattress suture. And we're going to use this additional pulley stitch, as you'll see later. The third and fourth passes are simply the mirror of what we saw initially. And so we're going to use this passing suture to pass the 3 sutures through the first hole, and then we're going to bring the last blue suture as the 4th pass, creating a second mattress suture. So here's your 3rd throw, and then you'll see the 4th throw. As an aside here, you see that I've worn down or taken the soft tissue off the bone down to a bleeding surface, and we're going to put the rest of the cuff down on that later. So this is not a necessary step if it's a small tear, but in the chronic and larger tears, I'll put in a retraction suture. This is just a free suture put through the free edge of the crescent tear. I'm going to put it outside the cannula so it does not interfere with the passing of any of my other sutures or tying. It can be incorporated later into lateral row anchors, which these days most of them will accept many sutures, but again, it's not completely necessary. So then we go and we tie medial row sutures first. We're going to just do sliding locking knots, alternating half hitches as long as you pass point and get a good square knot. You actually do not need to have a lot of throws on this. I did one study with a fellow years ago which showed that once you do a nice sliding locking knot, if you're taking those limbs laterally to lateral row anchors, there is effectively no slippage when compared to the same knot tied with many half hitches. Bottom line is you really don't need to complicate it. And since we're looking at efficiency and ways to work very quickly, even just not throwing an extra 2 or 3 half hitches on each anchor, well, that adds up and will speed up your surgery. So at the end of this, you now have 2 tied medial knots, medial mattress knots. The remaining sutures constitute the pulley sutures. That's the last step. So we're going to take one limb from each anchor and bring it laterally, as we often do. This anchor I like in particular because it makes its own pilot hole. It's a peak anchor. It's been on the market for quite some time. I've gone back and forth. I simply like to use anchors that have that metal tip, which will allow me to go ahead and put it where I want it. I don't have to drill a hole and then make another pass trying to find the hole. So this is going to show you the same thing with one important difference because I make a mistake here. So here I've got my sutures twisted. It usually isn't a big deal because you can kind of just force them down into the hole. Here I'm setting my tension, but as you're going to see here at the end of this, as I'm firing the knot, one of the sutures breaks. And I decided this was a good one to show, both because in the real world these things happen, and there's the suture letting go. But this shows also why I like this construct, because I have redundancy in the system. With the medial knot tied down, I'm not going to then have everything unzip. So in some knotless systems, if you have one of those lateral sutures come undone, they will just continue to slide through the medial anchor, and you really lose fixation in that part of the fixation. And if you've gone back and forth through multiple anchors, you can really lose some fixation. So the red suture here will show you where I've lost my fixation, but I've still got redundancy in the system. So the pulley stitch involves grabbing one limb from the remaining anterior and posterior anchors. I try to color coordinate and do the same thing every time. So you'll see I'm grabbing the purple sutures, pull them outside the body, and we're going to tie a knot outside the body. This is just a simple knot that's done in a kind of a square knot locking fashion. An outside the body knot is faster than an inside the body knot. It's one of the reasons this repair moves along quickly. So I'm going to pull each end of the remaining sutures to reduce this down into the body. And so this is what it's going to look like. I'm going to reduce the knot to the posterior anchor on the medial side, and then pull the second, which will tighten this loop. And so here's what it looks like on the inside. We're reducing the knot to the posterior medial anchor, and then we're going to have this nice pulley stitch, which we're going to tie a non-sliding knot to have this running between our anterior and posterior medial row anchors. And what that does is it reduces our repair along the articular margin. So if you imagine from inside the joint, instead of having kind of an arching fixation where there's one point reduced down with a billowing arch of tissue to the next anchor posteriorly, when you look inside the joint on these, it is reduced, and you don't see suture, you don't see arches. It creates a nice anatomic repair of the rotator cuff footprint. So the final construct looks like this. Again, the end result looks like, I'm sure, what most of you do. This is simply a technique which I found helps me because it does give some redundancy. It reduces the footprint anatomically. With a simple crescent supraspinatus tear, I use just 4 anchors. And so even though there are all those sutures, there's only 4 passes, 3 arthroscopic knots are tied, 2 of those being medial and 1 being the, you end up with 2 medial knots and then the 1 extracorporeal knot. So it's minimizing the steps, minimizing the passes, and you end up with an excellent repair that has some redundancy to it. It maximizes your footprint contract area. And I can expand this to include 3 medial and 3 lateral, or 4 medial and 4 lateral as the tears get bigger. And this is what I've been using for about 14 or 15 years here at the Andrews Institute. I've had great results with it. And I hope that this helps you in your practice. Thank you again very much for having me, and hope to see you at a conference in person soon.